I'm Dr. Davey Alleman, and today I'll be going through a deep caries case that many doctors would say needs a root canal and a crown. But here's why that isn't the case. Here we have a case where the patient traveled 3 hours to get a second opinion on a tooth that was beginning to have sensitivity to cold and was told by another dentist that this tooth needs a root canal and a crown. When you look at the pre-op x-ray, it would be very common for most dentists to say the decay is in the nerve and this tooth is going to die. Now, when I saw the x-ray, I wasn't sure how the tooth would respond to the stimulus of cold. This is still a very reliable way of assessing the health of the nerve. If I get response from a cold test, I will make the assumption that this tooth has the ability to heal. Now, in some instances where we have multi-rooted teeth, it is possible to have a false positive where one of the canals has vital tissue and perhaps one or two have a partially necrotic nerve. But you don't know this until about 1 year to 18 months after the procedure. So in these instances, I'm going to allow the tooth or give the tooth a chance to heal through these processes, which we will go over in this particular case. So after I applied the cold test, this patient had an elevated response to cold. The patient didn't have any percussive symptoms or any palpation symptoms, and there was no periapical radiolucency at the bottom of the root. We isolate with rubber dam and begin breaking the proximal contact. When you look at a caries lesion that is approaching crestal bone, this is my preferred method to improve my isolation. By opening the contact but not removing all the carious tissue, we can then do what's called a deep margin isolation. This deep margin isolation will be utilizing the rubber dam that is in place and the adjunct of Teflon tape. Teflon tape can be placed between the tooth and the rubber dam, and this will give an added benefit of not only preventing any blood or crevicular fluid from contaminating the field, but also it begins to separate the PDL fibers that can sometimes impede our banding as we do a deep margin elevation. So here you can see that the Teflon is in place. Patience is key as you slip the Teflon between the rubber dam and the tooth itself. So this soft, mushy, carious tissue is actually adding the benefit of giving some resistance as I pack the Teflon between the tooth and the rubber dam, and the dam is becoming more inverted. When we use caries indicating dye, this will guide our caries excavation. A guided caries excavation allows us to predictably remove the pathology in the periphery without exposing the pulp. Many dentists feel like the use of caries detecting dye is for a novice trained dentist or a dentist that doesn't really understand what hard sound dentin feels like. This is not the case. By utilizing caries detecting dye, this shows us the integrity of the hydroxyapatite that's encrusting the collagen. If it's staining pink, we know that there's been a demineralization process from the acidic attack. And if something stains red and is highly infected, we know that not only is the hydroxyapatite no longer present, but also the columnar form of the collagen has been compromised, and there's been a collapsing of the collagen, and this will result in a weaker bond strength. Now, these weaker bond strengths of both infected dentin and affected dentin as we approach the pulp should not be something that is feared. When we look at a tooth, our goal is to maintain the vitality, and we do this through creating a caries-free peripheral seal zone. This was discussed and outlined in the literature in 2012, where my father, David S. Alleman, and Pascal Monnier not only showed how to deal with deep caries excavation as approaching the nerve without exposing the pulp by using caries detecting dye and other caries detecting mechanisms such as a diagnodent. By understanding where we can be aggressive in removing the infected tissue, we will ensure that we have high bond strengths that help protect the weaker bonds as we are beginning to seal in the carious tissue next to the pulp. Here you can see that I've applied the caries detecting dye and have begun removing on the gingival floor, the buccal proximal wall, and also beginning the excavation towards the palatal. I have not removed any carious tissue on the axial wall, as I know that this is in close proximity to the nerve. As we reapply the caries detecting dye, we can see that the carious lesion is undermining the palatal cusp. This palatal cusp has now been deemed non-critical because it's impeding my visibility of our goal of creating a peripheral seal zone that is caries free. So the next step in this approach is to onlay the thin cusp that is undermined by the decay. If this cusp was also undermined by a crack, it could also be onlayed without running the risk of violating critical tooth structure. After I've onlayed the cusp, it becomes very easy to visualize the DEJ from the distal all the way to the mesial, and so I can take my burr, which measures anywhere from 1.4 millimeters to 1.8, and clean just inside the DEJ without worrying about exposing or creating iatrogenic damage and hitting the pulp. At this stage, we have completed our caries excavation. This caries excavation is very predictable with the adjunct of measuring, along with the use of caries detecting dye. Understanding that the nerve or a pulp horn typically lies between 5 and 7 millimeters from the cavo surface, and on average it's roughly 6 millimeters. We would highly advise that you stop at 5 millimeters from the occlusal surface and 3 millimeters from the adjacent contact point, or 2 millimeters from the DEJ or CEJ. So these measurements we can see on the distal box. We have gone 7, 8, perhaps even 9 millimeters without exposing the pulp. We've got clean, sound dentin wrapping around the palatal at this point. But where the pulp would be, and if you look at a bullseye, if you do any archery or any kind of shooting in your spare time, this is what it reminds me of. It's like that target, that bullseye. And here I can see my hierarchy of bondability. This hierarchy of bondability means that different parts of the tooth will exhibit different bond strengths at different times, and this rate is dependent on the amount of hydroxyapatite. So enamel has the most amount of hydroxyapatite. It will achieve its maximum bond potential relatively quickly, which would be 30 megapascals. Superficial dentin has a higher bond potential at 50 megapascals, but it'll take in the range of 5 to 30 minutes. Deep dentin has a bond potential of 40 megapascals. The pink would be classified as inner caries, and that bond strength would be 30 megapascals. And then the area of red, or infected dentin, has a bond strength of 15. So each of these sealabilities must be maintained if our goal is to allow the tooth to heal. And so when I first read the paper by my dad and Pascal Magnier, the measuring that they talked about and how to utilize caries detecting dye was very, very valuable. But the thing I gleaned the most information was, what are my bond strengths, or what are my bond potentials? Because once we truly understand that we can bond to infected dentin, inner caries, deep dentin, superficial dentin, and enamel predictably, then we can begin to mimic the strength of an intact tooth. And that's what biomimetic dentistry is all about. We then proceed with an air abrasion step to condition the smear layer, utilize a gold standard adhesive to improve the bond strength, but this bond has to be decoupled from fast maturing bonds so the slow maturing bonds can achieve its maximization. Because anytime that you place restorative composite, there is the potential of the composite to shrink towards the center of mass or to a faster maturing bond. And this will stretch that developing hybrid layer. So here, as I'm taking these pictures, there is a polymerization curve that is being achieved. And we want to allow that plateau to form before we start to do, in this case, our deep margin elevation. Now, after we do the immediate dentin sealing, we will resin coat with a 0.5 millimeter of flowable. This thin layer of flowable ensures that we have full polymerization of 40 to 80 microns, depending on the adhesive that you're using. And then also we get a reinforcement or a secure bond strategy that can be designated, weaker bond within the restoration that can help prevent catastrophic failure. This deep margin elevation is done with small increments, and this allows further time for the outer caries that is on the axial wall, more time to decouple or to not be stressed through additional layers. We can also see in this image, the fiber is placed on the axial wall, and that creates another failsafe and prevents polymerization stress above from distorting, stretching, or delaminating that seal that we work so hard to achieve. So this is what we call a biobase. A biobase is a dentin replacement. This ensures that we have our ideal dimensions for our indirect restoration. Our goal with a deep margin elevation is to elevate the margin so it's slightly supragingival. If we've elevated this too much, it is important to go back with a burr and slightly remove some of the restorative composite so we can get a more idealized contour from the restoration. In order to bond to cured composite, we have to air abrade. The air abrasion allows for a new chemical bond to be achieved as it increases the surface area of the cured composite that was done 1 week or 2 weeks in the past. After we've air abraded, you would isolate the adjacent teeth. This can be done with cut Tafelmeyers or with Teflon tape. And then we would acid etch the enamel and clean the surface of the air abraded composite. It's important that if you isolate with a Tafelmeyer at the time of cementation or during a deep margin elevation, that you do not air abrade at this time. If you air abrade a stainless steel band, you are going to learn from sad experience that will create enough indentations that it will be almost impossible to pull the band out. So this is after air abrasion and after acid etching. And then we place uncured bond on the biobase. If this restoration was ceramic, we would do different protocols for the intaglio surface, but in this case it was a composite onlay that the lab had fabricated. So we air abraded the intaglio, phosphoric acid etch, uncured bond, and we delivered this with a heated composite. And here we have the immediate post-op after we've adjusted the occlusion. And then here is a 3-year follow-up where the patient just wanted to get a checkup to make sure everything was holding up well. And we can see from the PA, no periapical lesion. The tooth was still testing vital. And then on the bite wing, you can see how deep this restoration was and how close we were in proximity to the crestal bone. The periodontium is doing well. If there's maybe one critique, is that maybe I could go back and polish some of the composites that I did at that time. This is a case that we get a lot of questions, and it's a case that we show in many of our training programs. I remember where we presented to a local dental convention, and one of the participants said, "Well, I would have just done the root canal. It would have been just as easy to do the root canal and do these procedures." Well, that would definitely improve maybe the office's bottom line. But when we look at the patient as more than just a procedure, but rather as a person, we can say, if this was my sister, or if this was my brother, or if this was my father or my mother, how would I approach a case? And this confidence to be able to bond to carious tissue allows us to understand that there is a miraculous nature in the human body to heal. And so if we can seal out the bacteria and maintain that internal cohesion with our restoration and the tooth, in many instances, these teeth that are condemned for root canals diminishes greatly. If you'd like to learn more about deep caries treatment and bonding to deep caries, check out the video linked here in the description. If you want to learn more about our training programs, you will find our upcoming in-person and online programs linked in this video description. Get bonded, stay bonded.